Welcome to this year's virtual conference, Making Data Good for Society. Thank you so much for joining us today. My name's Neill and I'm from the DAMA UK board. Now, this event is co-sponsored by the BCS Data Management Specialist Group and DAMA UK. It's an event that we hold every year, and until 2020 was an in-person event, but we had to embrace a virtual event last year, and we're repeating that this year. So if you're not aware of it, BCS is the professional body for computing, and it has a mission to make IT better for society. And the Data Management Specialist Group within BCS promote the better use of data by running data-related events and supporting development of data-related standards and guidance. And now DAMA UK is the go-to organisation for data management professionals. And we say that our mission is to nurture a community of data professionals in the UK who champion the value of data management. So this is one of just a number of events this week. And every day at 11 a.m. and 4 p.m. we have an event. And as you can see, we start on the slide, you can see on the screen on the red. And if you've already missed it, don't worry, these are all being recorded. But we started off this morning with implementing the National Data Strategy. We're just about to go on to the value of data in reacting to a pandemic. And you can see as we work round clockwise, all the various different topics that we've got. Now, there's a different link for every day. So if you register for more than 2 webinars in the same day, you can use the same link. But if you've registered for different days, you will be sent a different link for every day. So just remember that if you're joining us again tomorrow or later in the week, don't use today's link, but you will be sent one every day. So as a part of our event, the BCS has kindly offered us a 30% discount off all the list prices of data-related titles in the BCS book things. And you can see them listed on the screen there. This is only valid this week, and you can see the link there. So you might want to jot that down quickly so that you have that to hand. So before we start, I just wanted to let you know a little bit of housekeeping. We are recording this session today, and it will be available in the BCS members group's YouTube channel and also the DAMA UK website after the event. We are lucky enough to have, and now I'm going to keep saying this and getting it wrong, journalism with us today, and we have Alex who's waving away now, and they're capturing the events as we go in a really fun and engaging digital visualization, and they actually produced that a digital agenda that we shared on the first slide for this conference. So look out for these after the event. We will be sharing these. They're going to be a fabulous way to remind you of the key points. So you are all muted. We'd love you to ask Neill loads of questions. Neill's probably saying, no, please don't. But, we want you to ask loads of questions. So please pop them in the chat. And when Neill gets to the end of his presentation, I will ask him as many of them as we have time for. We've allowed about 20 minutes at the end. So do make sure you get your question in. And I tend to look at them in logical order. So the first ones will probably get asked first. So getting on to actually why we're all here, which is the important thing, I wanted to introduce Neill, who is he's the Digital Strategy Director for the Dudley Group NHS Foundation Trust. And he's kindly agreed to talk to us today about the value of data in reacting to the pandemic and shaping our future, which I think is going to be just, such an amazing topic and, really, really important. So Neill is actually part of a team who, in partnership with leading MBA schools, created the world's first business transformation methodology whilst at the global software firm SAP. During this time, he also led valued partnerships, consulting with firms such as Vodafone, where he led a 500 million global shared services transformation that delivered multi-billion-pound savings. Since then, he has delivered a digital strategy for 575,000 Worcestershire citizens, partners, and around 4,000 employees, which transformed county services. And Neill then became the UK's first chief data officer in local government, where he set up and inspired a shared purpose across public sector in a strategic partnership that integrated service delivery whilst leading Worcestershire Office of Data Analytics. So I think with that background, you were well placed to then sort out what we do with all our data in response to a pandemic. So I can't wait to hear this. So over to you, Neill.
Thanks, Nicola. Yeah, it's a great privilege to have Dudley here presenting today. I mean, the COVID-19 pandemic has had a devastating impact on public health and it's really impacted vulnerable communities around the world. So as nations continue to navigate their way through the crisis, the necessity of robust healthcare systems and services has become ever more apparent. I was watching the European Championships over the weekend and watching Christian Eriksen collapse on the pitch, and you really understand vulnerability at points like that. When I was working with West Mercia Police, one of the things I quickly understood that vulnerability can impact anyone at a drop of the hat. So I'm sure we're hoping, just trying to take you to the next slide. So I'm sure we're all hoping that the COVID pandemic will eventually transition into a world with less restrictions. The impact has been massive, and today I'm going to give you a whistle-stop overview of how it's impacted the citizens of Dudley and the region, our staff and our partners through the lens of data. So this presentation will not be a geek fest on data. We will focus on people and how we've collaborated to redesign how we deliver health services while simultaneously managing risk at the same time. Don't worry though, everyone, we will still cover a little bit of machine learning as we go through. So I've actually...
Neill, sorry, I don't think you're sharing your slides.
Ah.
Sorry, I was just trying to interrupt you just politely. Perfect, they're visible now.
Is that better?
Yep, that's great.
Okay, so you can now see reacting to the pandemic.
Sorry, I was on mute. Yes, I can. I can see that perfectly, as I'm sure everybody else can.
Perfect. So I'm going to cover this talk in a couple of areas. Firstly, reacting to the pandemic, and then shaping our future. So we're going to cover key roles within the hospital and the community, and how they contributed to keeping patients safe and flowing through the hospital. So in most cases that they were discharged back to the community. We'll also cover in a bit more detail, some key topics like end of life. And I'll spend more time here as there's a lot of emphasis that's been putting into helping families plan. And we'll talk about how data has actually played a part in that. At the same time as this COVID-related care, we've still done our best to maintain outpatients appointments, and we'll see how this was made possible. Then the second part of the talk talks about shaping our future. So the National Data Strategy covers some of these key aspects, such as unlocking data assets and driving efficiencies and improvements in public services. And we'll see this and other aspects at a local level in practice. Of course, it is about actually taking data and doing more than just having the data. It's turning it into insight, decision, actions, and outcomes. And I'll talk about that in the context of these key areas. I always like to sort of define what the problem is and therefore the opportunity. So on reflection, it was about keeping our citizens and staff safe while providing care during unprecedented times. And that meant we had a real opportunity really to empower people to collaborate using digital and data to make best use of our resources and meeting the needs of the population. So some people may be asking, where's Dudley? You know, as you can see there, we're part of an integrated care system. We're one place within a number of different other places within the region. So we're at the heart of the Black Country in the West Midlands, and we provide acute and adult community services for a population of nearly 450,000. So as part of a developing integrated care system, we're now working on new models of patient-centred care. And we run out of a key hospital at Russell's Hall, and then outpatient centres in a couple of different places, as well as over 40 centres delivering community care. In 2016, we created the Digital Trust Mandate, and that's improved patient outcomes and quality standards. And we've won a number of awards during this sort of time. Some context then in the years running up to COVID. On the left-hand side, you'll see like an aircraft hangar size of paper records, right? So going back sort of 2013 or whatever, this is kind of what you saw. And this is how we dealt with patient records. And then we started modernizing, going through the on-premise data center, and then through to the electronic patient record. And there was this vision to digitalize the hospital and its community services so that we could change the way that we deliver care. I always think, I've come from quite a varied background, and I always think that digital and data, that they're integrated, right? And we look at that and we ask and discover what our problems are and what the opportunities for service design are in order to change our operating model. And when doing that, we digitalize, we automate key services, etc. We look for that brilliant user experience in order to then improve our service delivery. And data really is at the heart of that. And often in public service, I think of people and I think the place and how I can then start linking those to objects and events. I said at the beginning of the presentation that this was about people, and in 2019, we introduced data relationship managers and a data coach as business partners to collaborate with our clinicians, operational staff, leadership and patients, and our vision of redesigning health services in the UK. And these key roles are translators of data into insight, and they coach non-data colleagues through the power and importance of data to achieve evidence-based decision-making. And they're aligned with the divisions of the trust, and part of their role is to help identify, understand, and influence opportunities to improve that data quality and promote the impact it has on organisational performance and patient care and safety. In doing so, they really coordinate with, they also coordinate with regional and national colleagues, and they have a direct impact therefore on how politicians make effective decisions using the data in front of them. So through to the COVID environment, and we knew we had to respond. So in March 2020, as the coronavirus outbreak accelerated, we needed to bring and accelerate pieces of work that we already had planned and in the pipeline. One example there on the left-hand side is around collaboration between the GPs and hospital clinicians. So this was taking the GP record and embedding it within our own solutions. And this visibility of data saved admitting doctors valuable time when assessing, for example, patients with dementia. So they could see whether patients were recorded on the dementia register, which gave them immediate confirmation as whether their symptoms were new or historic, and let us deal with the situation at hand. Meanwhile, pharmacists noted how much quicker it was easier to validate patients' home medications, a process that otherwise took a lot of logging into different systems or actually calling the GP practice. So that access to data, really key. And we were highly commended for this work by the Health Tech newspaper Tech Ladies Awards in 2020. In parallel, we'd created a sepsis dashboard to give senior clinicians an overview of the entire hospital population so that we could identify deteriorating patients and ensure the appropriate care and earlier intervention where required. Staff safety, absolutely critical, as you can imagine, in order not only to protect them, but also to give us sufficient staff to actually react to the pandemic. And it came at a time when we had that sort of significant depletion of clinical workforce with coronavirus symptoms. There was self-isolation, general sickness absence, and vacancies. So we had to do a huge amount of significant workforce modelling, deployment and redeployment, taking into account high risk and shielding staff and surging and super surge scenarios. So this was really working at pace and making sure that we developed integrated metrics of patient safety, health worker safety and quality of care indicators, and integrating that with our healthcare information system. And of course, you've got the PPE in the right-hand corner and the testing, etc. It really was one of the most full-on times that our clinicians have faced, and our operational staff there with data relationship managers and data analysts, etc., were there to support them. Anyone who's been in a hospital will know that critical is the patient flow and the ability to discharge. So in the latter parts of the year, our data relationship managers then spent a lot of time working with the trust coordinators, the site coordinators, to aid the data provision to allow that hospital flow. So we've seen significant improvements in the oversight and assurance available to all levels. And we were attending a meeting 4 times a week for site incident response, and making sure that we've got that whole live capacity report of bed position at ward, room, bed level, and then making sure that we then report that back up in a regional and a national perspective, so that we can start understanding as a nation as a whole where the pressure points are. One way of dealing with some of those pressure points was to introduce virtual wards. So as COVID patients hit 25% of our inpatients in early 21, the hospital really was in surge mode for critical care. So we created this virtual ward solution with scope for rapid access assessments and recording of pulse oximetry from people's homes. So we mobilized this in a week in early Jan. And we actually use shielding and retired staff to sort of operationalize and support to start people recover at home in what is known as a virtual ward. So that sort of pulse oximeter helps you monitor how your heart is beating, i.e. the heart rate, and the level of oxygen in your blood. And the blood oxygen level is then one of the ways in which the doctor or nurse can keep an eye on people's progress with COVID-19. And then we can use that data in order to make a call on whether or not we would actually need to then admit people, or if people are actually recovering safely at home. So yeah, a real bit of innovation there and a great use of data in order to monitor people. The end of life is something that we're really proud of in terms of the journey that we've gone on, and it actually started before COVID. So the aim of the end of life gold standard framework is to enable a gold standard of care to help people live well before they die, and to die well in the place and the manner of their choosing. So the priority has been the timely improvement of the identification of patients in the last year of their life. And we took an audit by the specialist palliative care team, and they published evidence at the time that 30% of all adult inpatients are actually in the last year of their life. And this demonstrated to our teams that the end of life was everyone's business. And to improve the end of life care for Dudley patients, a trust-wide initiative to implement the gold standard framework was implemented in 2018. And it's really helped a culture change across the trust, because it's helped during the worst of COVID crisis and ensured that we all work together to improve patient safety and care across boundaries. And we identified by the Dudley improvement practice that we needed to find metrics to drive improvements in end-of-life care, so that we could actually have measurable outcomes for patients and their families. And some of those included resources and metrics that would improve the patient outcomes, and that would allow us to do that via various different metrics. So we got a data analyst who supported the palliative care team, and we met with Leeds to develop a system to support the collection of those appropriate metrics in a way that would support them in a day-to-day functioning. And the development of these metrics fundamentally actually changed the culture of the wards and the departments, because they could see in real time the improvements they were making to patients and their families who needed that end-of-life care. So the outcome has been an increased recognition of patients in the last year of life, which is approximately 30% of inpatients at that time. During April 2020, it's now then been integrated as part of our trust integrated performance record at the staff request. So real demonstration of changing culture and using data for good. Surgery and outpatient transformation has been key to the running of the hospital. So every week we meet as a trust team to review how we can transform the patient experience. And this has carried on during COVID. And front and center is to improve the patient outcomes and the use of insight to drive those actions and outcomes. So for surgery, with the reduced ability and capacity to operate on patients, we've had to brought an increased need to plan and prioritize the urgent elective demand. So we've worked collaboratively with anaesthetists and surgery operations, and we've been tasked with sort of delivering improved insight on the pre-op assessment alongside admitting waiting list data. So in a nutshell, we've been working together to provide better visibility to clinicians and their teams on the patients awaiting surgery, and making sure that we do the cleansing, matching and visualization. So our frontline teams are able to change the way they work. And that's actually seen as well in that graphic on the right-hand side. So we've been working out how to do that outpatient environment. And that diagram actually describes how we've had a positive impact on patients as well, on their experience, by being able to deliver services in a virtual way. And that's really helped the patient themselves by less travel and the environment, and the fact that a reduction in CO2. Vaccine delivery, as you'd imagine, has been absolutely vital. It's been a real true co-design effort with our pharmacy and nursing colleagues and regional and national teams. And it consumed an enormous amount of energy and discipline to deliver on time for 2 centres, one at our hospital and one at the Black Country Living Museum. So the use of insight was right at the heart of the delivery, managing risks such as the vaccine and the people availability between doses and the inequity of access. And that's involved a flow of data from national systems for call and recall, booking, pharmacy, clinical capture, and no-shows to meet local delivery requirements. So that was a sort of summary of how we've managed in the COVID environment. And now I'd just like to talk about taking us and shaping our future. Again, I've put a problem statement. The problem being we cannot meet the current healthcare expectations and needs of the population. So communicating, consuming and acting upon the volume and velocity of care information far exceeds our capabilities. So we've got a gap that's rapidly widened, and having this ability to respond with investment and using insight to transform our services, we're not going to be able to cope. So therefore, we've already started this phase of working out how we can use this as an opportunity to meet the triple aim of healthcare, which is about the best experience of care, best use of resources, and the best health for the population. Again, it's about people and collaboration and redesign and risk management. So this second part then will take us through a little bit of background research, our vision, and the investment that we're making in analytics as a strategic investment. Anyone who's been with data for a good while, Nicola, I know that's you, will know that the 3 V's were originally brought in 2001, a guy called Dudley who talked about volume, velocity and variety. And there are a lot more V's of data now. And the couple that I'd just like you to reflect on for a moment is the value and the vulnerability. We've realized in the last few years how much value data can provide. COVID provided that in spades. At the same time, we absolutely need to know and understand about the vulnerability around making sure we do that in a secure way. There's lots of research there about making sure that we can maximize impact. This one here is from Imperial College and about impacting on health and wealth of the UK. And to do that, we absolutely need to collaborate with public and in order to realise the value of that. So we got a vision. That is a shared vision to put Dudley citizens at the heart of an integrated care system with a focus on improving the health and well-being, improved outcomes, and a more engaged community. So we want to allow citizens to access and co-author their own care records, supporting the ownership of healthy life expectancy and personalised health and well-being. Yeah. So therefore, we're looking to invest in analytics and insight as a strategic asset. And I want to cover 4 different areas in this space. The first one about secure infrastructure, making sure it scales, that delivered via cloud-based analytics and the speed of insight, unlocking data assets and making sure that we enable and empower people with modern tools. So when we actually started looking at secure infrastructure and how to deliver insight to improve citizen outcomes, we looked at that vision and some of the things that we would need to do. And it really came down to the fact that with data in future, we're going to have a lot more scale about what we do. And in order to do that, we're going to need a lot more advanced tooling in order to give that rapid generation of insight and make sure that that insight is done in a secure way, however it's accessible anywhere. And there's a lot of different specifics there on the right-hand side about what we'll require our technology to do. So in order to do that, we didn't actually have some of the skills ourselves, so we commissioned a partner to help us on that strategic journey, and to make sure that we didn't remain on premise and we didn't hold our service redesign ambitions back for 5 years, which is that sort of typical economic decision making around whether to be on premise or in the cloud. And we absolutely recognise that as Dudley works with its partners in the integrated care system, that insight will be at the heart of how we plan and deliver and redesign our services. And we asked ourselves a few different questions. One was, can we use the power of cloud services to visualise the end-to-end cancer pathway at an individual layer? Can we use automated tools in Azure to forecast a range of future demand scenarios in the cancer pathway? And can we use machine learning to uncover critical insights from clinical instant data and improve patient safety? And when we look at that and we look at whether or not that speed of insight is going to make a difference, we've thought in different ways, really. So strategically, is there an ability for machine learning to deliver those analytics that would normally require an analyst to deliver over a longer period of time? So we're thinking about forecasting and the cancer work that we talked about a moment ago. Performance. So whether or not, for example, we spend a lot of time doing clinical coding so we can understand the work that we've been doing and see what we can learn from that. And we think that from a performance perspective, we can then turn things that often take weeks into hours. From an operational perspective, I talked earlier on in the presentation about supporting the on-site discharge site operations team. And what we'd like to do in future is make sure that we can be a lot more predictive and helping people and understanding when we have a problem in the hospital and doing that before we actually start breaching. And that real time will mean, for example, we can turn things that sometimes take seconds even into sub-seconds. So on the cancer pathway, we've used what we've learned over the last couple of months is that we've been able to use these visual management tools to filter data and identify quickly variation in patient interactions, which highlights potential blockages in pathways. And that mechanism identifies and addresses variation in primary care referral patterns and conversion rates. So what that's going to do is allow us to understand and predict our demand management. It's going to allow us to address proactively patterns of referral. It means that we can share best practice between, for example, primary care that does that already in a really great way with others that perhaps could improve. And that will allow us then to explore that unwarranted variance and get quality improvement into our pathways. The second part then is around that sort of forecasting. So what this allows us to do is, with minimal coding this time, allow us to get that comprehensive forecasting on models. So that would allow us to do using click and drop functionality, pipeline creation, and machine learning run wizard for forecast creation. That means, importantly, that we can do these experiments that can be set up and run really, really quickly, and we can see what we learn from those and start putting things into practice. So it really gives us the ability to perform complex analysis quickly and without code, which will speed up our analytical work streams, and it will also enable more people to analyze the data, frontline clinicians, etc., gain the insight from it in a timely way. This next, I mean, this is a bit, it's not a joke, it's put there as a bit of a cartoon, but absolutely it's not a joke. We actually find in this modern way that we do find that some of our data is being held to ransom. So, you know, we've invested a considerable amount of time in working out how to improve our use of information to support our clinicians actually drive and deliver better services. But now we find ourselves in a position where some of our suppliers haven't actually caught up. And they do this by locking down our applications, not allowing us to reuse the information. So what's more, that's done on sometimes a very old product set and obsolete tech. So we need to do more in order to work out how to unlock those data assets, work with our suppliers, who some of them are being really responsive. Others will have to change undoubtedly. And that will allow us then, for example, to work in how to sustain our services. This diagram here is about the NHS sustainability model. And so what we're doing in the coming 3 months or so is making sure, first of all, that we ask ourselves from a diagnostic and a prioritization perspective from a division about across 7 key domains, such as workforce, about how we believe our services currently operate and how sustainable they are. We'll then do an in-depth analytical review, and we'll prioritize those using a lot more internal and external data, so we better understand our services, so that we can make recommendations and implement those recommendations. So using data, therefore, to transform our service delivery by unlocking those data assets in a number of different systems. And we also want to be able to unlock data so that actually our employees can play their part and that they can actually, with their records, for example, take much more charge about data quality and the timeliness of information. We want to be able to give citizens access to their own records. So again, they can play a lot better part in their own healthcare. And that will be two-way. So that will allow them, for example, to use things like devices to upload data, to share that with clinicians to monitor how people are getting on pathways such as diabetes and respiratory and even ophthalmology. So who will own the future? Well, you know, anyone who watches this space will have seen perhaps Tim Berners-Lee, the inventor of the internet, is now investing his time co-designing with others about how people will own and control their own data using a platform called Solid. Whether or not that makes it or not, I'm sure it's going to be super interesting about who will actually own the future in terms of access to records and owning their own data. And we really need to make sure that we stop holding people back from improving outcomes. So we really want to use technology and the data to change behaviours. And there are many different examples of that. So one way is around this automated machine learning text analytics. So this requires no coding or little to no coding and empowers people to perform these sophisticated analyses without comprehensive training. So the machine learning then automates time-consuming and iterative tasks like data cleaning, manipulative techniques with a single click by connecting data sets using intuitive interfaces. So that will then allow us to create pipelines that clean our data, pre-process unstructured text, and extract key phrases that provide valuable insights. And why will that be important? Well, this will help us on things like instant reporting or on near misses reporting. So for example, it could bring a proactive component to our weekly meeting of harm, where specific intelligence from instant reporting might highlight emerging near misses or instant trends early. Or in the case of serious incidents, it might give us rapid analysis to look back and forward at key trigger words that become possible for improved quality and safety assurance. From a workforce, I'm sure it'll allow us to better understand trends and staff sentiments and pulse surveys and friends and family tests, etc., etc. The list absolutely goes on. This example here is around that named entity recognition. So that extracts and labels relevant medical information from unstructured text. Anyone who's worked in healthcare will recognize the fact that we have a huge amount of this unstructured text. So within minutes of uploading the text, what we're finding is that this service actually detects and services medical concepts, it assigns assertions to concepts, it infers relationships between concepts and links them to common medical ontologies. So yeah, really impressive stuff. We're super excited about this and the ability to change our service delivery. So at the beginning of this section, I talked about the triple aim of healthcare. And I trust today that you've seen that we can use modern analytic tools to provide that significant opportunity to improve the quality and experience of care. And so to make sure that we have a direct positive impact on patient outcomes. The best use of resources is always important, how we can improve our performance, planning, productivity, and that's linked to that sort of cloud and that time to insight that we talked about earlier, and that best health for the population. So population health management, and that requires things to be done at scale. It allows us then to work with our partners on a system-wide basis and doing something that will actually have a truly impact on health outcomes. And of course, it's about our people as well, and making sure that we can actually give these modern tools to our team and make sure that in future, those bright graduates or apprenticeships coming through can be an essential part of our recruitment and retention opportunity. So that concludes the talk today. I trust you've enjoyed it, and it gives us some time for questions.
Thank you, Neill. That was absolutely fascinating. I think that was really, really good. We have a couple of questions already in the chat, but I'm going to just take advantage of being the chair of this session and ask my own question first, while everybody else is obviously going to type frantically away. I just think, firstly, thank you, Neill. That it's been absolutely fascinating hearing what you were doing. I would say from what you were sharing, it actually sounded like you were doing some quite progressive things before the pandemic hit, and that perhaps it helped you accelerate. Do you think that that's perhaps one of the good things that's come out of the pandemic, though, that it's forced people to perhaps consider data in a healthcare setting in a way that it didn't before?
Yeah, that's true. I mean, there's always that joke, isn't there, about what's actually instigated it, yeah, whether it's like the CIO or whether or not it's the pandemic. You've correctly identified, though, without having the proper plans in place, you wouldn't be able to roll out at the pace and to be able to deliver the insight that we did. And in terms of, has the pandemic allowed that progressive element of it? For sure, because it's changed mindset. This presentation's as much about people and collaboration. And you've got to remember that our clinicians and our operations staff are there to safeguard people. And I talked about risk as part of this. And we've always been taught to minimize risk. And of course, that means that we take a very considered approach to delivering innovation, because quite rightly, the patient is at the heart of that, and making sure that we deliver an environment that you would want yourself or your family to experience. So that said, that COVID comes along, and then we do have to respond in a different way at a different pace. And therefore, we probably rolled things out slightly more quick. Well, we have rolled out quite a lot more quickly than we would previously. And that has enabled us to sort of accelerate and transform our care. I think, though, it's also important to reflect as well that, as well as increasing the pace, we now also need to go back and understand exactly what we did do, and making sure that we stabilize everything, because there's been great innovation. And I think the next stage, as I talked about a lot, is about that engagement with citizens around their use of data. And there's a couple of things around that. One, they need to get used to the way that we do things. And secondly, they need to trust us in the way that we do that. So yes is the short answer. And it's been certainly exciting to be able to do that in a progressive way.
Excellent. So before we go on to some of the questions that have come in, I just wondered if it's okay to ask Alex to share what he's been drawing for us. So I'm sure you're dying to see what he's made of your presentation. So I think perhaps we need you to stop sharing so Alex can share.
Just press the stop share.
Yep, that's it. Thank you, Neill. Is that okay, Alex?
Yep.
Am I dumping you in?
My screen, you should be able to see what I'm drawing.
Wow.
I think someone needs to pin it first. Sorry.
That is. Oh, it shows you how
stunning,
much
Alex.
We covered, in a small time. That is really, really good, Alex. That's fabulous. So excellent. So is it okay to leave that on the screen while we do the questions?
I'm going to be working on drawing the questions, so I'm going to have to move on to the stream, I'm afraid. So.
Okay, no worries. We'll take it off the screen then, and we'll look forward to seeing the final version. But that's fabulous. So, Neill, we've got some very more specific questions now that we're finding people have got, and that is, many people are. Many GPs are using System 1, but in terms of data, it's been actually designed, or the individual implementations of it have been designed by their own IT professionals. Therefore, the data of one GP is slightly different from another. My question is, how are you going to tackle the data consistency across all the GPs? That's a good question.
Oh,
I don't know whether the answer's going to be
you asking me to solve all of that. We won't do today. You know what, though? It's a great question, because I think the key part of that is, or the way that I see that, is that it's not actually about sharing all of the information. So there are some key elements there that really make a significant difference. So I think what we've been doing is focusing on some of those key elements, like medications as an example. So if you share those medications between different providers, that gives significant insight for people to operate in a different way without having that data. So I think that it will take a long time, actually, before we unearth the true value of all of that data set within the GP record. And like anything, it's about taking chunks out of the elephants and working your way through it.
Yeah, no, I think that's a good answer. And I think, it is very, very frustrating being on the receiving end of it. We even had, and I'm sure you hear all these horror stories. I had my parents-in-law live with us, and on the same day, they both had telephone doctor's appointments last week, where the doctor said they both needed blood tests. And they said they would arrange for the district nurse to come and do it at the same time, because they're both housebound. Nurse turned up yesterday, which I was quite impressed that it was a Sunday, to just do a routine blood test, but only to do one of them she had no records for the second one. So they've lost an opportunity where they could have done it with no extra time. And I can see this is where this sharing of the data and standardizing of it, but that was one GP surgery. They just, obviously the data didn't get through at the same time, and the planning is such. But the possibilities are amazing. But yeah, I think you're right. It's not going to happen overnight, is it? We've got a long journey ahead of us.
Yeah, and that's why it's going to actually require some really experienced people, and blended with actually others who don't have that experience, and putting that melting pot together to get the innovation and the ideas, and then to work out how we can do that in a really productive way.
Very true. So there's a good question here about, has Dudley NHS Trust worked with any other organisations, both commercial and public, in capture and management and benefit realisation from their data? Because I think Glenn was asking you if that has collaboration been a significant part of this.
Yeah. So I mean, first of all, we work with a stack of different providers, right? So we work with a large amount of private sector providers in order to improve the way that we work. We absolutely want to hook into that innovation. From a benefit management perspective, I think that's really interesting. It's something that's really close to my heart. So going back over a decade ago, when I was working for that software organization, benefit management was a key part of the transformation journey that we took people through. And I've looked to bring that in to the work that I do now. I also then I went to the market actually, and ended up with a contractor recently who I brought in, who had a wide variety of background, working with places like HMRC, through to Environment Agency, through to different private sector organisations. And we worked collaboratively to work out what our benefit approach would be for Dudley. The reason being is we want to attract further investment into digital and data, and just putting a financial lens on that isn't going to enable that further investment. So I think that diagram that I showed around the outpatient transformation, which enabled you to start working out, okay, what's the impact to the environment? What's the impact to the patient? How does that improve their lives, etc.? That's a fundamental part to how you actually manage the benefits. So yeah, we've looked at it at length the last few months, and we're going to be looking at it in even more depth in the coming years.
Excellent. No, I think that's a really good example of your contractor, the fact that actually bringing people in with very different, varied backgrounds, maybe not a healthcare expert, but could bring in some other ideas. And you've got an organization full of people that tell you what may or may not work in a healthcare setting, but you get that innovative ideas. Brilliant. So we have one more question, and I don't know, it might be a big answer, so it might be the only one we've got time for, which I'm sure most people on the call are aware that there are fairly advanced plans to sell anonymized patient data held at GP practices for commercial use, and it's not been very well marketed to the UK public, but there's been a bit of flurry in the news, I think, the last couple of weeks, and even though I think as data professionals, we understand that it may well result in the supply of better medical products, services, even drugs possibly. But it's arguing that it's arguable that perhaps data sharing isn't a medical issue. So if you agree with that, where should the responsibility to encourage the sharing of anonymized data best sit?
Oh,
question.
I mean,
Sorry.
It's such a big question, isn't it? You know what? I don't think it's the intention to sell data whatsoever from the NHS. So that's my take on it. We're looking to use it for health and care planning and research purposes. So it's where organisations have a legal basis and a legitimate need to use that data. I think that's the first thing. And I think that's a fundamental difference between selling data. So you're right. Engagement with public and with citizens absolutely vital to explain that. And it is a complex and quite a new area, right? So even though you've seen the private industries over the last decade or so use data and monetize it, etc., it's still something that a large percentage of the population don't understand, right? I think in the short term, if I was in charge, for example, in the short term, it would be about engaging people, having that conversation, and not selling the data, however, still using it for research and planning purposes, because as COVID has taught us, we wouldn't be where we are now if we weren't using data for that planning and for research. So I'm not sure I've answered all of the question, because I don't think I'm necessarily the best person to answer all of that. However, I've given it a good go, sat from where I am today in the role that I do.
No, I think that's really useful, Neill, and I agree with you. And I think some of the things that I've seen, I think people's concerns are around is it anonymized, or do they have your personal data? Because I mean, I've spoken to people in similar roles to yourselves in different NHS trusts, and I totally get that there's some amazing things that can be put together. And you've been giving us examples of them today. When you analyze the data en masse, instead of just looking at Nicola's data, you look at everybody that has a certain health condition and see who responds well and start getting these trends. And I think that, that is a really valuable thing. But as you say, I think perhaps that's not explained because, as data management professionals, we have to remember that the majority of the wider population are not data literate yet.
Yeah, that's right. Thanks. That's a better explanation, Nicola, than I even gave. And to tell you what, it is about anonymizing the data when you're doing it for the planning and research. We're not giving your name alongside all of your own personal conditions, etc.
No, that's very true. I think we've got time for just one more question, if that's all right with you, Neill.
Sure.
I don't understand the question, but hopefully you will. It's because I'm not being a medical data expert. How do you think the open referral standard will impact on GPs' ability to understand the wider determinants of health data, particularly in social prescribing?
Can you take me through that one again?
So they're talking about how do you think the open referral standard, so it's not a standard I'd heard of, will impact GPs' ability to understand the wider determinants of health data, particularly in social prescribing. I wonder whether are they meaning that using, I understand that using data helps you better understand the social prescribing and how that can fit in and help. But I'm to be honest, I'm not sure. So I don't know if Kelly, are you able to
it goes partly to what you were talking about before about the standardization of data being absolutely key, so that we can compare and use that standardization to understand the data and compare it then against other data sets. So in terms of the wider determinants, making sure that that we can then prescribe that social prescribing, it might be the way that we actually can offer different types of healthcare than we actually do now. That's as much as I actually know on the subject. So it's as best as I can answer at this moment.
No, I think that's pretty good because Kelly's just added clarity that it's a new data standard. It was only just released today, so it's very new. So, and she shared the link. Excellent.
Thanks for that. Appreciate it. I'll be making sure that I learn more about that.
But yeah, no, that does sound, anything that encourages the standardization of data is going to make everybody who's working in analyzing that healthcare data job easier, isn't it, to get those insights from it. We have another one popped up from Sandeep, who said, excellent talk. That's good. How did you go about upskilling or training those interacting with data? And what were the main challenges? Is this where perhaps the data coaches and partners came in that you were talking about?
Yeah, I mean, I can't speak highly enough really of forming that sort of business partnership role within your organization. So data relationship managers actually allows them to then work with different specialities to make sure that they use data in a way that can provide the patient outcomes that we're all looking for. So first thing, I suppose, is that we've helped the data relationship managers get the skills that they need. So not data folk aren't always known for their sort of ability to converse in a really articulate way about business problems. Yeah. So our data relationship managers absolutely can. So there's one thing there around making sure that team's equipped with the right skills. Secondly, then, it's about making sure that you then engage the clinicians and operational staff to understand key concepts around data. It's been in place just over a year or so, so we've taken the organisation a long way. We've still got much more to do, and anyone who's worked in data a long while will know and that topic around data ownership and governance, etc. So that's the journey that we're on, and I'd welcome actually any input from people here who've got any thoughts and ideas about how they've seen that successfully elsewhere, and just get in touch with me.
Excellent. Well, I think loads of people should get in touch with you and copy your ideas. So is that something, this is probably just a final wrap-up question from me, is that something that is encouraged? Because we have, I don't know how many different NHS trusts across the country. Is this something, because obviously you've worked on this in Dudley, but do you get to share this to others and say, look what we've done? You don't have to learn the hard way. You can just take what we've done and apply it to your data.
Yeah, we're always sharing. The great thing about public service is that we're not in competition, right? And well, interestingly, actually, I'm pretty new to the NHS myself, right? And I sort of came in at a point where actually it was more encouraged around this commissioning way of delivering service for competition, yeah, between different providers. However, now with the integrated care system, it absolutely is all about collaboration in future. That's my mindset anyway, right? So I believe in sharing openly, working out in the open, making sure that any insight that we have, we share with others, because I believe that, that's replicated, you receive that additional feedback from other places that allow you to improve your performance. So so we're very open, we share stuff, and there's plenty of other hospitals that I've been in collaboration with these last few months talking on different topics.
Excellent. That's excellent news. So, perhaps we'll see some of the innovations you shared today coming to our local healthcare trusts before long. So that has been absolutely fascinating, Neill. I can't thank you enough. It's been a fabulous. We've set the bar very high for the start of the week of our webinars. Just wondered if, Alex, are you able to give us a final look at what you've been doing before we finish up?
Yes, I think you should be seeing
so
what I have.
Neill probably finishes.
Oh,
sharing.
yeah, I need to stop sharing. Hang on.
And somebody else spotlight me, or I'll do it. There we go. In the Q&A.
Excellent.
Yeah. I'm so looking forward to getting a copy of this, Alex.
This is so cool. Thank you so much, Alex. Thank you again, Neill. And thank you, everybody, for joining us. And don't forget, we have got so much more going on this week, all around our theme of making data good for society. So thank you very much, everybody. And we'll see you at one of our other events later this week.
Thanks
Bye.
all. Bye all.